Hello, I'm Dana Marie Kennedy from AARP, Arizona. Thank you for joining us today. I want to welcome you to this important discussion about recognizing the early signs of Parkinson's disease. AARP is a nonprofit, nonpartisan member organization and has been working to promote the health and well-being of Americans for more than 60 years. AARP is providing information and resources to help older adults and those caring for them. Today, we're talking about recognizing the early signs of Parkinson's disease and how a family member or a friend can start an appropriate conversation about possible Parkinson's-related changes with their loved ones. We will talk about why early diagnosis and early intervention is important. To ask questions during the webinar, you can use the question and answer function or text 661-360-5544. That's 661-360-5544 to ask a question. We have had folks join our webinar while I've been speaking, and I want to extend a welcome. I'm Dana Marie Kennedy with AARP Arizona, and I want to thank you for joining this important discussion on recognizing the early signs of Parkinson's disease. We're talking with leading experts, and we'll be taking your questions through the question and answer feature on our webinar, or you can also text your question to 661-360-5544. I'd now like to introduce you to Holly Shill, MD. She is the director of the Muhammad Ali Parkinson Center, the Bob and Renee Parsons Chair in Parkinson's Disease and Movement Disorders, and a professor in the Department of Neurology at Barrow Neurological Institute. She is board certified in neurology, diagnosing and treating movement disorders, including Parkinson's disease. Dr. Shill, the floor is yours.
Hi, everyone. Thank you very much for inviting me to speak today. I'm going to just get my slides up here. Make sure that everybody can see what we're doing here. Good. All right. So I'm ready to get started now. So thank you, everyone, for spending an hour of your time this morning with us. So I'm coming to you from my office in downtown Phoenix, Arizona, right at the Muhammad Ali Center. And it's my pleasure to share with you a little bit about what we know about Parkinson's disease today. So let me get started here. All right, so just a little bit of what we're going to discuss today. So first, we're going to just discuss a little bit about what is Parkinson's disease. We're going to talk about who gets Parkinson's disease and what we know about what causes it. And certainly, most important for you all, a little bit about what are those early warning signs that you might be developing Parkinson's, how it's diagnosed, and then a little bit about why it's important to make a diagnosis of Parkinson's. So first, just a little bit about what Parkinson's is. So it's a neurologic condition. It's a brain disorder. There is a specific part of the brain that gets affected by Parkinson's. It's in the kind of midbrain part of the area, in an area that controls both movement as well as kind of mood, emotions, cognition, that type of thing. So a certain population of cells called dopamine neurons get affected as one of the first kind of areas affected in the brain. And this is what really leads to some of the symptoms, what we call the motor symptoms. So it's a combination of both movement symptoms, which we'll talk about here in a moment, as well as some other aspects of both brain function as well as bodily function. We'll talk a little bit about all of these things. So it is a progressive neurologic condition. So it's in the family of neurodegenerative conditions similar to Alzheimer's disease and ALS or Lou Gehrig's disease. So it progresses over time. But fortunately, it's one of our most slowly progressive neurologic conditions and probably one of the most treatable conditions. So I hope to leave you with some hope about this condition if you are indeed developing it. So most importantly, symptoms can be treated with Parkinson's. So it's very possible to live well with Parkinson's for many years. So who gets Parkinson's disease? So I guess, first of all, it's a disorder of aging. So that's probably the most important concept. So most of the people are diagnosed over the age of 60. So the average age of diagnosis is about 60, 61. So it certainly can affect people during their working careers, but most commonly it's affecting people as they age. So men are slightly more affected than women to be diagnosed with Parkinson's, and that's an interesting thing that we don't fully understand. We don't really think that there are hormonal influences as to why men are more affected than women. And it may actually do with some of the potential occupational exposures, environmental exposures that may lead to increased risk. I'll talk a little bit about that here in the next slide. So, and it's estimated that about 1 million people are living with Parkinson's disease. So, and around 60,000 people are diagnosed in the United States each year with Parkinson's. So it's a relatively common disorder. About 1% of the population over the age of 60 will develop Parkinson's disease. And that risk does go up with aging. So by the time you get to about age 80 or so, it can be as high as maybe 10, 15% of people may have some of the early changes of Parkinson's disease. And so what causes Parkinson's? So I wish we knew for 100%. It's really hard for me to have a patient sitting in front of me and say, this is why I think you have Parkinson's disease. So it's very much an area of research, and we do have some understandings of it, but it's not fully understood why people might develop Parkinson's. So we know that there are genetic factors in some individuals. So if you look at just the general population with Parkinson's, about 2 to 3% of people may have a gene that's a causative gene for their Parkinson's. So, and then if you have a family history of Parkinson's disease, that percentage goes up. So, for instance, if you're a member of the Jewish population and have a family history of Parkinson's disease, it may be as high as up to 20% of people may have a gene for Parkinson's disease. So there are some genetic risk factors, but that's not the explanation in most people. In fact, even if you carry a gene, some of the most common genes, it is not 100% likelihood that you'll get Parkinson's. So there's a lot we don't understand about these genetic causes of Parkinson's. So for the vast majority of people, though, they probably don't have a genetic cause for the Parkinson's. So, and this is where the environment might play more of a role. We know that people who grow up in farming communities, exposure to well water potentially, some industrial exposures, so some solvents and things that have been linked to Parkinson's disease. So people in the military who served in Vietnam and maybe had Agent Orange exposure might be at higher risk for Parkinson's. So there are some environmental factors that may play a role. And then there's also the important sort of gene-environment interactions, which we're just beginning to understand. So for instance, there might be certain genes that in the setting of the right environmental exposure really kind of collaborate, if you will, to increase people's risk of Parkinson's. And that might be the kind of main cause, if you will, of Parkinson's, or these gene-environment interactions. So, and then finally, of course, age. We recognize that it is a disorder of aging, and that is really the biggest risk factor. And so there's actually quite a lot of trying to understand, what is normal aging and how do some people kind of go out of that normal aging to then develop Parkinson's. So what are the symptoms? So I think just talking a little bit about some of these symptoms. So first of all, it's primarily, we think of Parkinson's as a movement disorder, so a motor disorder, so features of problems with movement, and we'll go through some of these things. But there can also be a variety of what we call non-motor symptoms that sometimes are more problematic for some of the patients than the non-motor symptoms. So, and there are many possible symptoms. It's amazing. You talk about just about every body part potentially could have a symptom related to it. But not everybody gets every single symptom, and that's fortunate. And fortunately, even if people get some of these symptoms, they tend to be fairly mild for most individuals. So we'll talk about them, but I don't want everybody to have a panic attack about some of these symptoms. It's not like you're going to get every single symptom throughout the course of Parkinson's. So, and then we'll talk a little bit about kind of what symptoms start when. So the first symptom I think most people think about with Parkinson's is the tremor, and that's considered a motor symptom, so kind of a physical symptom of Parkinson's, something that's observable. And it's what's called a resting tremor, which means that it comes out when the hand or the leg is quiet. So, maybe the hand sitting in the lap or holding the steering wheel, kind of quiet, holding the steering wheel, or down at the person's side, the tremor may come out. And it typically starts on one side of the body. So it doesn't seem to matter whether you're left-handed or right-handed, which side of the body that it starts on. But that idea of a unilateral or one-sided resting tremor of either the arm or the leg Sometimes the jaw can be affected too, but that idea of that tremor is an initial symptom of Parkinson's. And tremor is present in about 70% of people with Parkinson's disease, and is often what drives people to go see the neurologist as a question of Parkinson's. So, and so not to panic, actually most tremors are not Parkinson's tremors. So there's a condition called essential tremor, which is a more common cause of tremor. Probably about 5 times more common than Parkinson's. So it's important to recognize that all tremor is not Parkinson's tremor. And so I think to talk with your doctor about whether they think that that tremor really is a Parkinson's tremor or not. So another symptom that's unique to Parkinson's and is really kind of more common with Parkinson's is than other tremor disorders, for instance, is small handwriting. And so what happens, people often have sloppy handwriting as they get older, and that's not really what we're talking about. What we're talking about is handwriting that often starts off fairly large, but then kind of tapers off as the patient writes. So it actually progressively becomes smaller. And so some people have written small all of their lives, and that doesn't mean you have Parkinson's disease. But a new onset or a new change in your handwriting as you age is kind of what we're talking about. So and again, if Parkinson's is starting on your dominant hand, you're going to notice smallness of handwriting. If it's starting on your non-dominant side, then you may not notice the small handwriting potentially until kind of later in the course of Parkinson's. But it can be the early sign in people where it's starting on that dominant side, so where the side that you used to write with. Another non-motor feature now of Parkinson's is loss of sense of smell. So, and this is an interesting symptom that can often predate the tremor, the physical symptoms of Parkinson's, sometimes by many years, a decade or more, where the loss of sense of smell. So people can notice a difference in smelling foods like bananas, dill pickles, licorice, that type of thing. So it's also important to recognize that not all loss of sense of smell is due to Parkinson's. So in fact, less commonly due to Parkinson's. So again, not to panic if you have lost your sense of smell, because it's possible that it's related to something else. So one of the more common things in the last year or so, since about March of last year, is COVID. COVID actually not uncommonly causes a reduction in sense of smell, and usually that sense of smell recovers after the COVID illness is passed. So, and there are other viruses, even influenza, for instance, can cause some reduction in sense of smells. So there are a lot of things that can cause a change in sense of smell. But if you start to put some of these things together, like the reduction in smell and the tremors and some of the other features that we're going to talk about, then you're going to be more suspicious that the person's loss of sense of smell is indeed related to Parkinson's. Trouble sleeping. This is another interesting symptom that can go along, that can start in the early stages of Parkinson's. So sometimes people have very vivid dreams with Parkinson's, and this can start sometimes a decade or more before the tremor starts. So another non-motor feature of Parkinson's. And this is where people have very vivid or active dreams where they kind of seem to fight in their sleep or talk in their sleep, thrash around. Sometimes might actually hit their sleeping partner, sometimes might actually roll out of bed if it becomes problematic enough. So, and this is what's called Rem Sleep Disorder. So it's something that happens during our normal dream sleep or Rem sleep, rapid eye movement sleep, but becomes very much more active in the setting of somebody who's developing Parkinson's disease. So, and that's a very important symptom for us to ask about for somebody presenting to us in the clinic. So the big hallmark, so the next symptom to talk about is these motor symptoms of what is called kind of bradykinesia or troubles moving. And this is a big hallmark of Parkinson's. What we call bradykinesia, what the neurologists will call bradykinesia, which is slow movement or stiff movement. So sometimes people may present with a loss of arm swing. They're not swinging their arm when they walk. They might have stiffness in a shoulder that's not moving as well. Some people even present with a frozen shoulder where it's actually kind of locked up, that the stiffness has progressed to the point of a frozen shoulder. They may have some stiffness when they walk or not moving a leg, kind of dragging a leg when they walk. In fact, sometimes people worry that they might have had a stroke, but really it is more the Parkinson's symptoms starting. And again, it tends to start on one side of the body. So reduction in an arm swing, reduction in the leg movement. where they just seem to move more stiffly and slowly. So the important thing with Parkinson's is it's typically not painful. So if you think about arthritis or joint pain or something like that, it's typically painful when you move, whereas with Parkinson's, it tends to be not painful. So slowness and stiffness that's not accompanied by a feeling of discomfort or pain is more suggestive of Parkinson's. Another non-motor feature to talk about is constipation, and some people with Parkinson's can have actually quite problematic constipation. And again, this is another feature that can predate the motor symptoms, so predate the tremor, the stiffness, and slowness symptoms. So constipation can be an early symptom of Parkinson's. So it's important to recognize, though, that constipation is very common as we get older. So up to 70% of patients can have, or 70% of older individuals can have constipation. So not to panic if you have constipation, but just to mention that it is a little bit more common in people developing Parkinson's disease. So it is fairly normal to have some constipation as we get older, but it is a little bit more common in Parkinson's. So softness of the voice, or a soft voice, or difficulty projecting the voice is another Parkinson's symptom. So people may notice that they just have trouble projecting or trouble getting their voice up. People are asking them to speak up. So, again, there are other causes for soft voice. You may have a flu virus or something that's affecting the vocal cords. And usually that's a temporary thing. And then once that recovers, the voice comes back to normal. But something that's unrelated to cold symptoms may prompt a suspicion for Parkinson's. So masking of the face, so a reduction in facial expression. So just like the body movements, you can have a reduction in your ability to move the face. And sometimes people get misdiagnosed as having depression symptoms because they look like they're just not expressing themselves. They might look like they're not happy. But really, it's really a reflection of the difficulty moving the facial muscles. So this is what's called facial masking. So important to recognize there are some medications that can cause some of this slowness of movement too. So very important for your doctors to look through your medications to make sure that it's not just a manifestation of the side effects of some of the medications that you might be taking. Dizziness and fainting can happen with Parkinson's. So Parkinson's can affect the body's ability to control blood pressure. And so sometimes people can have some lightheadedness or drop in blood pressure when they go from sitting to standing. That's present in about a third of people with Parkinson's. Usually not too problematic for people, but it can be a prominent symptom. So important to recognize it because it can be a cause of falls. And so we want to make sure that we're asking about that particular symptom, as well as addressing it if it is a problem. So, and again, important to recognize that there's a little bit of this as people get older as well. So kind of a little bit of hardening of the arteries, if you will, that might happen as people get older. And a lot of medications can cause the side effect of dizziness. So not all dizziness is related to Parkinson's, but it can be related to Parkinson's. So important to mention it. So stooping or hunching over, so kind of a change in posture. Again, a kind of part of that moving more slowly overall. People tend not to be as upright with Parkinson's. So, and again, this is something you can see with normal aging. If you have some osteoporosis or something like that as you get older, you might have a change in your posture over time. But again, it can be a symptom of Parkinson's. So, and it's part of those motor symptoms of Parkinson's where people start to have a little bit of slowness and ability to, their reduction in their ability to stand upright. So again, to look at that, but to not assume that it is related to Parkinson's. It may be a feature of aging or arthritis in your neck or back. So how do you know if you have Parkinson's? So, there isn't a specific test that we tell people to go get with it. It's something that we're working on to try to develop tests to really formally diagnose Parkinson's. There are some imaging tests that can be used that can help with the diagnosis. We're looking at biopsying certain areas of the body, doing skin biopsies and things like that, but that's still kind of, some of this is still very much in the research arena. So most of it is really just coming to a doctor and, talking about your symptoms, having them evaluate you and really providing a good clinical exam. And that's where the diagnosis is typically made. So I often have patients come to me and say, they just watched me walk down the hallway and said, this looks like Parkinson's. And sometimes it is actually as straightforward as that, just watching how the patient moves and walks, and that can be enough to make a diagnosis of Parkinson's. So we really want to look for those symptoms, that slowness of movement, the tremors, the nature of the tremor, some of the non-motor symptoms, and put it all together to be able to make a diagnosis of Parkinson's. So there are neurologists that are, certainly very capable of making the diagnosis of Parkinson's. And then there are more specifically what are called movement disorder specialists like myself, who have had actually additional kind of fellowship training in the evaluation and management of people with Parkinson's disease. And so these are what are called movement disorder specialists that kind of specialize in Parkinson's. So now after listening to everything that I've had to say here, I want you to think that, if you're starting to think that maybe I have some of these symptoms of Parkinson's, first of all, don't panic. Even the diagnosis of Parkinson's, most patients can have many decades of kind of fulfilling lives living with Parkinson's. It's a very treatable condition, and there's a lot we're learning about it and working to develop therapies that really try to slow the progression of Parkinson's. And really help people manage their symptoms. So I really want people to understand that it is something that is a very treatable condition. So the goals of Parkinson's treatment are really to help people manage all of these symptoms that I talk about, to have these symptoms have the least impact as possible on their day-to-day function, their quality of life. And there are a variety of treatment options, many medications that have been approved for Parkinson's and are used for its management. And so we tailor our treatment really to patients' symptoms. And there are different treatments that are used at different stages of the disease, and not all people need to be treated right away, for instance. And some of the symptoms are mild enough that they really don't need to be treated at the earliest stages. So it's important to just talk with your doctor about all these different treatment options and what's appropriate at the different stages. So there are medical treatments, there are actually surgical treatments. There's a treatment called deep brain surgery that is used to treat the symptoms of Parkinson's. So a variety of different treatments depending on where people are in the course. And early diagnosis is really important. I mean, I think first from an education standpoint, making sure that people are, understand what symptoms are related to Parkinson's, and then really helping to manage these symptoms as best as possible. We want to make sure that we're, counseling people, talking about prognosis, providing support. It's a lot of work we're doing with the Parkinson's Foundation, who's helping to support this event today in terms of really helping people live a full quality of life. So living the best quality of life possible with Parkinson's. Research, there's research going on and things that are trying to slow progression of Parkinson's. And so early diagnosis, I think, allows people to have access to some of these things as quickly as possible. So I'll finish with that, and thank you for your attention. I've left some phone numbers up here for more information if you're interested in making an appointment with us at our center, our website here, as well as an email. If you just want to shoot us an email and ask us a specific question, we'd be happy to get back with you on that. So thank you for your attention, and I look forward to the question and answer part. Turn it back over to Dana now.
Thank you so much, Dr. Shill. That was great information. If you've just joined the webinar, I'm Dana Marie Kennedy from AARP Arizona, and this is a live webinar to talk about recognizing the early signs of Parkinson's disease and sharing of information of where to find resources to help you as a community member. We're talking with Dr. Shill, and I'm about to introduce you to Jessica Bartsch. And if you would like to ask any questions, we will be taking your questions during the question and answer feature of the webinar, or you could also text 661-360-5544. Jessica Bartsch is a community program manager for the Parkinson's Foundation. She received her Master's of Science in Community Counseling from the National Louis University in Chicago. She earned a National Certified Counselor, an NCC credential from the National Board of Certified Counselors in BCC, and holds a Foundation in Aging and Disability certificate from the Boston University School of Social Work. I have my certificate from Boston University as well. And after her father's diagnosis of Parkinson's disease, her passion for and career merged. And Jessica is inspired every day by her family, the PD community, and the hope for a cure. Jessica.
Thank you so much for that welcome. I really appreciate it.
Thank you. So again, we're talking with Dr. Holly Shill and Jessica Bartsch. And if you would like to ask any questions, we'll take those during the question and answer feature of the webinar, or you can text 661-360-5544. Let's discuss what we just learned from Dr. Shill and hear from Jessica about her experience as a family caregiver and her work at the Parkinson's Foundation. Jessica, say that I am seeing my family member for the first time in a while after this year, and I noticed a few of the symptoms that Dr. Shill just described. How can a family member or friend start an appropriate conversation about the possibility of Parkinson's disease-related changes with their loved one?
Well, that's a really good question, and it's very practical because we know that many people are in this position right now. So how do we start that delicate conversation? Well, first and foremost, and it might seem very obvious, but it's really important to be calm during this conversation and show that we are coming from a place of love and concern. So if we set that tone right from the start, we are going to lay the groundwork for a better conversation. Secondly, the language we choose is also very important. So the thing is that when we start this conversation, it's really about exploring, right? So we want to have this conversation to see is how long has our loved one been experiencing this symptom? Do they have more than one symptom? And does our loved one actually recognize that they are experiencing these symptoms? So it's really important to use something called I statements. And an example of an I statement would be something like this. So if I said, hey, Mom, I notice right now that your left hand is shaking. And you know what? I noticed it last time I visited you as well. Is that something that you've noticed? As opposed to me saying something like, hey, Mom, your left hand is shaking. And I noticed it was shaking the last time that I saw you too. And do you see the difference between those conversations? So it might not be very obvious, but the way that someone perceives those statements is very different. So when I'm saying, hey, Mom, your hand is shaking, I'm just making a statement. And it's almost like shutting down the discussion right from the start. You're really not creating this environment where people are going to want to talk to you. They're going to be a little bit defensive. But if I put the onus more on myself and I'm saying, hey, Mom, I've noticed this, then people tend to be more apt to discuss and just kind of move that conversation forward. So something that's also really important to note is that if your loved one is resistant to talking at that moment, you need to press pause on that conversation. I think so many times we are solution focused. And when when it comes to our loved one, we want to have this conversation. We want to set up a doctor's appointment and we want to, get help for our loved one, right? And sometimes that's not the way it goes. Sometimes our loved one might be very resistant. Maybe they think we're overreacting. Maybe they actually recognize these symptoms in themselves. And this is almost like more of a validation that they're experiencing those. So they might be very resistant. And if that's the case, we say, just pause, come back to this at another time, because it is an important conversation to have and you need to have it. And if you push it at that moment, they might not have that conversation with you in the future. And lastly, I want to share a very useful tool. So before you have this conversation with your loved one, it's actually really important to have the conversation with yourself. And I mean, literally. And I know that might sound silly to some people, but if you actually take the time and you talk it out and you role play what that conversation might sound like, you can think of responses that your loved one would give, responses that you would give. It really helps you to keep your thoughts focused and organized. And most importantly, it helps you to recognize the emotions that you are feeling. Because let's face it, this is a potentially really emotional conversation. So if you process those emotions prior to going into this discussion, it will help you to stay more calm and focused.
That's great information, Jessica. My next question is for Dr. Shill. If I have a conversation, as Jessica described, and we agree to be evaluated, who should we try to see first? And what providers are involved in a Parkinson's diagnosis?
Right, very good question. So I guess, really, if you have maybe starting with your primary care physician would be the best option. And certainly if you have a good relationship with your primary care physician that you've known, maybe for years, that would be a really good place to start. So because they may have been noticing things in you as well, and maybe just didn't think to talk with you about it, or just hadn't really crossed their threshold to say, hey, maybe something's going on. And so I think it would be good to start with the primary care. And some primary care physicians are really good at diagnosing and managing Parkinson's. Maybe they've had specific training in it. A lot of the geriatric specialists, for instance, have had specific training in Parkinson's care and management. But most of the time, they're going to probably want you to see a neurologist. So they might refer you directly to a neurologist or give you some names to see. So and then there are a variety of neurologists too. So if you live in a community that has a good general neurologist, that's certainly a really great place to start. So and then, as I mentioned in my talk, there are also specific specialists in Parkinson's disease that are called movement disorder specialists. So depending on the community that you live in, and whether you have access to somebody like that. So sometimes movement disorder specialists tend to be more in the kind of bigger cities, bigger communities. So I think starting with your primary care physician first, maybe a general neurologist, depending on where you live, and then it's certainly a movement disorder specialist if you do have access to somebody like that.
So once we're seeing the right provider, what happens during an appointment to evaluate somebody with Parkinson's disease? And can you walk us through that appointment?
Sure. So I guess, first of all, what do I like to see? I mean, first of all, if you've had any evaluation prior, certainly if somebody's already been suspicious of the diagnosis, it'd be nice to get those records from that person. If they've done any previous workup on you, so say you did talk with your primary care physician, they might have ordered a few tests. Sometimes you might have had a brain scan or something like that. It might be good to get those records to us. I always like to see those so that we don't have to, kind of start right at the beginning if there's been some evaluation along those lines. So, and then really, the evaluation is just like any other evaluation for things. I mean, we go through all of your symptoms. Some of the things I talked about, asking you about all of these different symptoms, not only the physical symptoms, the non-motor symptoms that we talked about, the sense of smell, the sleep issues, those types of things, asking about your mood, asking about your cognition. And then the other things we like to talk about, certainly all your health conditions, any other health conditions, medications that might increase people's risks of having Parkinson's-like symptoms. We definitely want to make sure that we go through those. So, and then, of course, we'll do a physical exam, and it's mostly a neurologic exam, so looking at the features of Parkinson's. So we're going to watch you move. We're going to have you tap like this and tap like this and open and close your hands and watch you get up and watch you walk down the hall and just look at how you move overall. We're going to look for that tremor and might try to bring it out during the evaluation. We might get a sample of your handwriting to see what your writing looks like. So all of those types of things will be part of the evaluation. We'll check your balance, check your stability and reflexes and things like that. All of those will be part of the neurologic examination. So, and then at the end of things, we'll have a heart-to-heart discussion about what our findings are, and I tend to be very, upfront about what I'm seeing and make sure that we're, telling people why we think it's Parkinson's. And then, we spend the rest of the time talking about what we're going to do about it. I always encourage people to bring someone with them to that first appointment. I think that's very important. I think, it's something that's even if you're suspicious of it and you're actually pretty sure that you have it, you've read all the symptoms on the internet, you've listened to this talk, I think it still hits people pretty hard to get that formal diagnosis. So I encourage people to bring someone with them to that initial appointment, whether it's their spouse or an adult child or somebody that can just really kind of help them through that visit and hear what's been happening. So,
great. And Jessica, what's the family caregiver's role in these appointments and evaluations? And I might also ask, what is not involved in these appointments for the caregiver's role?
Got it. So a role of a caregiver is essentially that of support, right? Based on your loved one's needs. So as Dr. Shill was saying, it's really important to have someone come into these appointments with you. I would say to have the caregiver be involved in all of the appointments, right? And especially these first appointments as well. So how do you support your loved one during this? Well, one, way is to actually help them be prepared. And that happens prior to the appointment. So I always tell people it's really great to create a list of questions and concerns. And especially when you're going into this first appointment, and the operative word here is to create a collaborative list, meaning your loved one and you are having this discussion. You're writing down symptoms, you're writing down concerns, any other questions that you might have. And then you bring those into the appointment. And the thing is that once you get into that appointment, and let's say your loved one is maybe not able to communicate as well or articulate themselves well, you can be their voice in that appointment. And basically, you know that everything that you're talking about, you can feel confident knowing that you created that list together. So this is your loved one's thoughts and feelings, right? So you can be their voice at that moment. And I think actually one of the most important roles of a caregiver in these appointments is to be a second set of ears. I think about my dad who lived with Parkinson's for 13 years, and my mom was his full-time caregiver, and then a couple of us siblings were like part-time caregivers, but my mom was at every appointment. She was his voice when he needed it. She was his advocate. She was always his second set of ears. So she would bring in a notebook, and she used one notebook that was specific to these appointments, right? And she wrote down everything. There is so much that's talked about. And, if your loved one is starting a journey with Parkinson's, this is going to show this natural timeline of these appointments that you can always refer back to. So being that support and being the second set of ears. Something I would say for the caregiver not to do is if your loved one is fully capable of communicating and answering all these questions, let them do it. Let them talk. This is about them. This is their story, right? It doesn't mean that you're not a part of this conversation. You are. You're there with them. And it doesn't mean that you can't add to this conversation, but don't interrupt. Sit there and listen, take notes. And then if you want to, gently interject sometimes your loved one might be omitting some really important information. And it's okay again to kind of add that gently, again, using the I statements. Mom, actually, I did notice that you were stumbling a little bit more. Maybe the doctor asked that question about balance or something. You can gently interject, but your role, if your loved one is able to communicate, is really just to be there in a supportive manner.
Great. And Jessica, how do people find out about the National Parkinson's Foundation information and resources for family caregivers if they are diagnosed?
So I always tell people once they start their Parkinson journey to go to parkinson.org. We have different areas for people who are newly diagnosed, for caregivers. And if you are starting a new journey with Parkinson's, I say to go to parkinson.org/newly diagnosed. On this landing page, you can order our newly diagnosed kit, which really has this great insert about important key questions to ask your doctor. It also has this brochure that says the 5 best steps to living with Parkinson's. Other great resources we have, and more of a comprehensive list of resources is parkinson.org/resources. And if you're Spanish speaking, it's parkinson.org/recursos. And I'm sure I did not pronounce that correctly, so I apologize. But basically, this is a very comprehensive list about ways to connect with our helpline, our wonderful helpline, who's actually staffed by Parkinson experts, a really great first step in a Parkinson's journey. But it lets you order books. It helps you to order our Wear and Care kit. So it's a really great comprehensive site.
Great. Thank you so much, Jessica. And Dr. Shill, you spoke a bit about early diagnosis and early intervention. What is the biggest benefit to being diagnosed as soon as possible?
Right. Yeah, so a few things. So I think, first of all, diagnosis, I think, first of all, is just some comfort level and knowing what's been happening with you and then putting a label on it. And I think there's some comfort in knowing that. So, and spending a little bit of time with the doctor going through, which symptoms are related to Parkinson's and which ones aren't. And I think just from a comfort level, people start to feel more secure about, what they've been experiencing and knowing, oh, it's just the Parkinson's kind of thing. I think that's always very helpful for people to know what symptoms are related and what are not. So, and then treatment, if the treatment if the symptoms are actually interfering with your quality of life and your function, then starting treatment really can help with that. So So, if you've been having symptoms of slowness of movement and trouble with your walking and that sort of thing, and you start on treatment, you can expect to have improvement with that. So, and then the final thing I think is also just kind of being familiar with what's going on research-wise, because one of the things we really like to instill in people is kind of that hope for a better tomorrow. And a lot of people who are newly diagnosed with Parkinson's actually are really great candidates for some of the research studies that we've been doing. And so just having access to some of these kind of cutting edge technologies and treatments is really the best time to do that actually is at the time of diagnosis. So a lot of good reasons to get a diagnosis. So, and then just to really plan your future, how am I going to live now more fully with Parkinson's? So, and that might change a little bit than, kind of what you had planned before Parkinson's. And so, so the earlier you get started on that, I think the better quality of life you end up having when you're talking about 5 or 10 or 20 years down the road.
Thank you. And we are about to get to everybody's questions and answers. And if you do want to ask a question, you can do it in the Q&A feature of the webinar or by texting 661-360-5544. And for both of you, what is one takeaway or closing thought that you'd like to share with individuals and families who suspect a Parkinson diagnosis? Dr. Shill, can you start us off?
Yeah, so I guess the takeaway really is that Parkinson's is a treatable condition. So even though it's in that neurodegenerative family, I mean, it really is very much a treatable condition. And it is really possible for people to live very full quality of lives with Parkinson's. So it might change a little bit based on what you had kind of planned for your retirement years, but at the same time, it could still be very, very productive. And there really is quite a bit of hope and exciting things going on for the future as well.
Anything you want to add, Jessica?
I do. Since my role in the foundation is really to, coordinate these educational programs in my chapter, I really believe that knowledge is power, and that the more you know about, a disease like Parkinson's, the better quality of life you can live with it. So educate yourself, stay active, because medicine working out is, and being active is like medicine. So I say just exercise, be active, and know that you are not alone in this, and that there's organizations like ours that are here to help you.
Great, thank you. And I'm now going to turn it over to Alex Juarez, our AARP Arizona Communications Director, for participant questions. Alex.
Excellent. So Dr. Shill and Jessica, thank you so much for being here with us with our AARP members. And we are going to go to the first question from Kathy, and she is asking, can electroshock therapy cause Parkinson?
All right, so that's probably a question for me, I would think. So the short answer is no, that we don't think of electroshock therapy causing Parkinson's. So what I would wonder about, though, kind of as part of that question is potentially some of the medications that are used to treat some of the psychiatric issues that are associated. So if you need electroshock therapy, presumably that's because you have a psychiatric diagnosis, and some of these psychiatric medications may cause what looks like Parkinson's symptoms. So that you might see that in the setting of somebody who has been going on getting ECT therapy.
Excellent. Thank you so much, Dr. Shill. We will move on to the next question. Joan, is there dementia that can go along with a Parkinson's diagnosis?
Yeah, I'd be happy to take that question as well. So the answer is yes. So there is a form of dementia, basically called Parkinson's disease dementia, PDD, that can happen after many years of diagnosis of Parkinson's. So it tends to be a later stage thing that people eventually will, or eventually may develop a dementia. Not everybody does, but some people can. So there's also an important diagnosis too that is called dementia with Lewy bodies, where the person can have a dementia as a primary diagnosis, and then that can also have some Parkinsonian features. So they might have some tremor or slowness of movement. But that's really the dementia is the primary diagnosis, and then there's some Parkinsonian features that might go along with it. So yes, long and short, there can be dementia, both certainly with the dementia with Lewy body diagnosis, and then with more advanced stage Parkinson's.
Thank you. From Brenda, can a traumatic head injury from a blow to the head increase a person's risk of developing Parkinson's?
Yeah. Again, a question I think I can answer. Yeah, the answer is maybe. There have been some studies that suggest that people with a history of serious head injuries, head injuries associated with loss of consciousness and need to go to the emergency room to get evaluated, those type of more serious head injuries, those types of head injuries may increase people's risk of Parkinson's a little bit, although they're not necessarily completely causative. So, for instance, not all NFL football players develop Parkinson's disease, or boxers, or things like that. So it's not like it's completely a cause, but it may increase people's risk slightly.
Great, thank you so much for that. And the mention of the NFL concussion, that's very important in what's going on with the NFL there. The next question is from Sean, and she's asking about restless leg syndrome. And has restless leg syndrome have anything to do with Parkinson? And does having RLS indicate more of a chance to get Parkinson's over time?
Short answer is no, not really. So restless leg is a very common diagnosis. So occasionally you'll see people with both Parkinson's and restless leg syndrome. So, and then they're treated with the same medication sometimes. So some of the restless leg medications are actually medications that are also used to treat Parkinson's. So there's some overlap there. But basically, no, restless leg syndrome does not increase somebody's risk for Parkinson's disease.
Excellent. Thank you so much. We have an anonymous person that wrote, with genetic risk factors, does that mean if a relative has Parkinson's, I am more likely to develop it?
Yeah, slightly, so so if you have somebody in the family with Parkinson's disease, especially a first degree affected family member, so either a parent or a sibling, it does increase your risk slightly. But not substantially. So, and there are studies going on right now looking, actually run through the Parkinson's Foundation, the PD generation study, where we're looking for genetic markers of Parkinson's. So people can actually get tested. So patients with Parkinson's can get tested for these genes. And then, of course, if they're positive, that really may increase the person's risk of having a hereditary form of Parkinson's, and thereby, transmitting it or having it in other family members. So if somebody's concerned about that, they could actually have their loved one tested for some of the more common genes for Parkinson's.
Thank you, Dr. Shill. I think this is a follow-up question from the same person. I have pain, but have also some of these symptoms. Should I still get evaluated? Does having pain rule out Parkinson's?
Yeah, I think it's certainly, if you're concerned, if you've listened to this talk and you have a number of the things that we've talked about, it would be worth bringing that to the attention of one of your treating doctors and just say, hey, I listened to this talk and I'm worried I have Parkinson's. I've got a family member with Parkinson's, and what do you think? So.
Right, exactly. And for those people that are interested in the telephone number for the Parkinson's Foundation, the number is 1-800-473-4636, or also 1-800-4P like Paul, or Parkinson's, D like disease, .info. So again, 1-800-473-4636. Their websites, parkinson.org/newly diagnosed. Or you can also visit parkinson.org for the general site, parkinson.org. The next question is from Shelley, and she's asking, my dad has been diagnosed with Parkinson's. Is this pre-Parkinson's?
Yeah, so the question about Parkinsonism, it sounds like. So yeah, so it's interesting. Yeah, so sometimes we will call people Parkinsonism if they have some of the features of Parkinson's, but we're maybe not quite sure that it is Parkinson's disease. So, a really good example of that is maybe they're on a medication that could potentially cause some of the symptoms or signs that we're seeing. So some of the features that we're seeing. And so we're not sure. We're saying, is this the medication, or could they potentially be developing Parkinson's disease? So we will usually call that Parkinsonism in that state. So I think that's something you could ask the doctor about. Is it related to the medication or related to something else, or how likely do you think it is regular old Parkinson's disease, or what we call idiopathic Parkinson's disease, which is what we've been talking about here today.
Excellent. So Joan has a question in regards to dementia. Is there dementia that can go along with Parkinson's diagnosis?
Yeah, I think we kind of talked about that, but yeah, the answer is yes. You know, if you have Parkinson's for long enough, it is possible that you can get cognitive decline as part of Parkinson's. It tends to be different than what we see with Alzheimer's disease, so it has its own unique features. So so that's, you know, if you're concerned about that, something worth talking with the doctor about. So
wonderful. We have another question, an anonymous person that says, your old brother was diagnosed with Alzheimer's. Then he had some falls. Doctor thinks that he may have Lewy body disease. I learned there may be Parkinson's associated. Our mother had Parkinson's. Please comment on relationship.
Right. Yeah. So that we talked about this concept of dementia with Lewy bodies, where it's the cognitive disorder first. So, and some people that get initially diagnosed as Alzheimer's just because Alzheimer's is a little bit more common, but then maybe there's some other symptoms and things that the patient's experiencing, which lead you to say, maybe it is actually this dementia with Lewy body diagnosis. So for instance, if people have tremor or slowness of movement, in addition to the cognitive issues, then you might be more suspicious for dementia with Lewy bodies. So those patients also may have things like hallucinations as part of their disorder that may, you know, and that's, you know, unusual in people with early Alzheimer's disease to have hallucinations. And so if you see that in the setting of somebody with dementia, it makes you more suspicious for Parkinson's. So, and the Parkinson's disease and dementia with Lewy bodies are related in this sense. So I always think about dementia with Lewy bodies as sort of a top-down Parkinson's. So it affects the same changes that you get in the lower part of the brain for Parkinson's disease are similar to what you get in the cortex for people with dementia with Lewy bodies. So they're really kind of two ends of the same spectrum. So Parkinson's in the lower part of the brain, dementia with Lewy bodies in the upper part of the brain, but really the same kind of processes that are actually happening in the brain. So they are related.
Excellent. So we are a little bit under 10 minutes before we end the webinar. We still have time for a few more questions, but a follow-up, and I believe you've already touched on this, but can you, what treatments are available to lessen the dementia type effects of Parkinson's disease?
Yeah, so right, that's a really good question. And there are treatments for cognitive decline or dementia associated with Parkinson's. So it's actually a lot of the same treatments. In fact, it is really the same treatments that we use for Alzheimer's disease. So there is a family of medications called what are called cholinesterase inhibitors. That's donepezil, Exelon, those types of medications, and then another medication called Namenda. And so there's several medications that can be used to treat the cognitive symptoms of Parkinson's disease. And it turns out they actually can help a decent amount in people. So it's important if somebody is experiencing cognitive decline with Parkinson's to ask about those particular medications because they might be useful medications for them.
Great. A follow-up question from Shelley. In addition, he has 6 of the symptoms that Dr. Shill described. How many symptoms does one need to have before it's considered Parkinson's and not Parkinsonisms, or before medication is considered? Sorry if I butchered that.
Yeah. So the way we've officially diagnosed Parkinson's is you have to have what we call 2 out of the 3 cardinal features of Parkinson's. So, and the cardinal features are the tremor, the rigidity, and the slowness of movement. So these motor features that patients experience. So we ask about those symptoms and we look for them on clinical exam. And if patients have those symptoms or those signs, we are able to then make a formal diagnosis of Parkinson's. So now say the person just has some minor symptoms that, maybe they have the loss of sense of smell and they have the sleep disorder that we talked about where they have very active dreams. We might worry that person might eventually go on to develop Parkinson's, but if they don't have the tremors and the slowness of movement, we can actually call it Parkinson's. So in those patients, we will call them prodromal Parkinson's, where they have symptoms that are very suspicious for Parkinson's, but they're not quite enough to make the diagnosis of Parkinson's. Hope that helps.
Excellent. Jessica, this question might be for you. The question is, do you seek opportunities for business partnerships to help provide a recreational outlet for people who have Parkinson's? If so, who would you recommend I contact?
You seek business, okay, for business partnerships to help provide a recreational outlet. You know, I would, that's really a really good question for our helpline. I don't know the answer to that right now, and maybe I'm just not on 100% understanding that clearly, but we can definitely, if we do a follow-up, I can get an answer to, you know, put that in a follow-up email for the attendees if that's something that we can do.
That's fantastic. That would be great. Thank you so much. We appreciate that. Let's see. We have question for Jessica. It says, Jessica, my brother has been recently diagnosed, but is in denial. Is it okay for me to speak up? What should I say to him to help him process it?
So a lot of times, denial is a really natural part of this process, right? As with any chronic illness, that someone gets the news about that. So, and it's actually really a part of the way that someone actually processes that information themselves, the person who is receiving the diagnosis. So I would definitely say it's okay to speak up, but I would make it more like in a supportive manner, just making it saying, hey, you know, I'm here to talk or to listen or to do whatever you need right now. And maybe they're not even at that point yet, but you can just kind of put it out there. And then maybe that'll gradually be to, you know, I can come to a doctor's appointment with you if you want. You know, we can attend an educational program to learn a little bit more about this, like once they start opening up, or being more open to that idea. But what I really would do was just say, I'm here to listen to you, because a lot of times if someone gets that okay to do that, you know, maybe you will get that phone call at some point and say, hey, I need to talk this out. You know, like I'm upset, I'm scared, I'm all these things. And really within that conversation, you will help them process it, because really it's going to be just a back and forth, and really just be there and be supportive of them.
Absolutely. We have less than 5 minutes, so we're going to try to do a speed dating here, question answer here. Okay, so here I'm going to butcher this again. Is carbidopa levodopa still an effective medication for early Parkinson's? Sorry about that.
Yes, it is the most effective medication for Parkinson's.
Okay, great. Fantastic. Bob has a question. What should a caregiver be prepared for when dealing with Parkinson's? Are there special precautions in the house that need to be addressed?
I think in general for a caregiver to, you know, prepare for dealing with Parkinson's is, again, educating themselves, learning as much as you can about this disease, so you can prepare for what may happen in the future. As far as precautions in the house that need to be addressed, a lot of things we talk about is, you know, a lot of times people who have Parkinson's may, you know, have issues with balance, or they might not be able to take bigger steps because sometimes movements become smaller. So let's say you have an area rug. A lot of times we say to remove things like area rugs because it will, you know, decrease the chance of having a fall. You know, if someone needs more help around the house, like as far as like, you know, putting grab bars in the house, in the bathroom, just ways to keep people safer, that's also a good idea. Again, these are not things that have to happen right away, but just, you know, having that discussion, just thinking of like possible home modifications that you might need to make. Maybe that is, you know, changing a bedroom to, you know, the first floor, making sure there's a bathroom on the first floor. You know, if you want to think long-term with these things that might possibly happen, I would think in that way and prepare the house that way.
Fantastic. Is difficulty swallowing and cough part of the symptoms?
It can be. So sometimes people with even early Parkinson's disease can have some very mild symptoms with their swallowing. So, and then with progression, people can start to have a little bit more symptoms over time. So yeah, it can be, although it's not common that it's a major issue for patients.
Great. What does amantadine do for Parkinson's?
Amantadine is something we often use for tremor in early Parkinson's disease. And then it can also help to combat other involuntary movements, a type of movement called dyskinesia, which is a side effect of their dopamine treatment. So there's a couple of places where we would use amantadine.
Okay, and the final comment here, it says fitness outlet. My guess is it good to have maybe like a fitness house to take these patients to a fitness outlet?
Yes.
Excellent. Very
And if you're in Arizona, feel free to call us. We would be happy to connect you with people with, places locally for you. So we'd be more than happy to help you with that.
That is wonderful. That's the last of the questions that we have. So Dr. Shill and Jessica, thank you so much for answering these questions. And Dana, I'm going to turn it back to you.
Thank you, Alex. Great job. So that concludes the question and answer segment on behalf of AARP Arizona. I want to thank you to everyone for taking part in today's webinar discussion about Parkinson's disease. And just want to ask our moderators if you have any additional closing thoughts. Looks like we are good. So once again, AARP Arizona, thanks to Dr. Shill and of the Barrow Neurological Institute and Jessica Bartsch of the Parkinson's Foundation, we want to leave you with the closing thoughts that if you're noticing a few more of these symptoms in yourself or a loved one, it's important to bring it up with your physician and have your concerns evaluated. Parkinson's is not a death sentence, and treatment and early intervention helps people live longer, better lives with the disease. For family caregiver resources, please visit or call 1-888-687-2277. For questions about Parkinson's disease, signs and symptoms, go to parkinsons.org or call 1-800-4PD-INFO. Thank you all for participating in the discussion on this important topic. We apologize if we were not able to answer your question. You can also obtain valuable information by going through AARP publications on our website at aarp.org or by calling 1-888-687-2277. Thank you and goodbye. This concludes the program.